Alright, hello everyone and welcome to the Symposium presentation for the Cunningham Clubfoot Brace team. My name is Josiah Lamberton and I am a senior biomedical engineering major here at Messiah, and I have been the team's SPM for the last school year.
And my name is Bennett Liney and I'm a junior biomedical engineering student.
With that, here's our project introduction.
Cunningham Clubfoot Brace, or CCB, project works with orthotist Gerald Cunningham and the Kira International Hospital in Kijabe, Kenya, to research his CCB.
Clubfoot is a congenital birth condition where the feet are bent upwards and inwards at birth. Clubfoot is caused by the tendons in the leg being shorter than they should be and occur in one or both legs.
Clubfoot treatment occasionally begins with a surgery, called an Achilles tenotomy, to physically lengthen the tendons in the leg. The standard method of a clubfoot treatment is called the Ponseti method, which consists of a casting phase to slowly reset the foot and a bracing phase to prevent relapses and maintain corrections.
The goals of the project are twofold. First, the team hopes to determine how effective a Cunningham brace is compared to the traditional Steenbeek braces currently used at Cure. Second, the team is working towards providing Cure with information on how long a Cunningham brace can be used.
These goals would show evidence that the CCB is a worthwhile alternative brace, allowing the hospital to use it as an extra tool to both provide better clubfoot treatment and save money. The CCB has been successful at the Cunningham Clinic in Maine, but that is only with the brace being used once. Individually, a CCB is more expensive than a Steenbeek brace. However, at the Cure Hospital, using one brace for at least 2 patients would be economically advantageous.
The team has been pursuing these goals through 2 largely independent streams of work. Regarding the efficacy of the CCB, the team conducted a site trip to Kijabe in May 2025 in order to gather force data from clubfoot patients with both the Steenbeek and the Cunningham braces.
Since returning to the United States, our team has been conducting data analysis on the Kenya data and working towards presenting it in an academic setting.
For the reusability side of the project, the team has been developing a pneumatic fatigue machine to simulate the conditions of long wear by a child. Both the helix pieces and thigh pieces of the CCB are to be tested to collect these results. These 2 sides of the project will come together to provide a definitive answer on the lifespan and usability of the Cunningham brace, leading to better clubfoot care in Kenya and hopefully beyond.
Alright, so with that being said, here's
Cunningham Clubfoot Brace.
Here's our outline for our time together today. I'll first take us through some brief background on the project, just what we are, what we do, why we're doing it. Then we'll talk about both the fatigue testing and force analysis sides of the project that the video mentioned. First off, as a brief comparison of the 2 braces we're working with, we have the Steenbeek brace on the left of the slide and the Cunningham on the right. Some brief high points: the Cunningham brace often takes off a good 2 to 3 years of treatment compared to the Steenbeek brace, which is a major selling point of the Cunningham brace. But the major downside currently is the Cunningham brace is a higher cost and it's less tested than the Steenbeek brace is. Our project's main goals all surround if that Cunningham brace is economically feasible to be reused at the Cure Hospital in Kijabe.
And our project is to determine to tell Cure and Hope Walks that the CCB is a worthwhile alternative. We're doing this quantitatively by telling them the brace lifespan, as well as qualitatively by collecting data and comparing it to the Steenbeek's brace.
First off, we'll discuss that fatigue testing that I had mentioned before. So, in previous school years, we've discovered that through various testing methods, the thigh piece of the CCB is its weakest part. So this part right here is known as the thigh piece. The infant's thigh sits right below this part, and then this sits on the inside of the knee. So as they bend their knee, this part gets bent back and forth repeatedly. Our client, Mr. Cunningham, has mentioned that they often see plus minus 10 degrees of deflection in that location right there. We determined that that is the weakest point of the entire brace and would most likely be affected by repeated use. So we've been focusing on designing a fatigue machine to test that exact location and see how long it will last under long-term use conditions. We have settled on pneumatics because it allows us to have minimal friction and wear on components. It's air-powered, so it's very easily accessible for us, and we can both push and pull the brace with relative ease. Overall, pneumatics gives us a constant amplitude of motion, frequency, and force, letting us get the exact same data with every single brace every single time. This is our current pneumatic fatigue machine. Some major highlights of this thing here: we have a brace attachment at this part of the machine, if you can see my mouse. That essentially slides over the brace like so, almost sandwiching it, does not pinch it at all, does not damage the brace in any way, only gripping it firmly enough that we can move it back and forth, doing it the exact same constantly. We also have an aluminum clamp down here right there, and that fixes the knee portion of the brace straight to that support structure, enabling us to really isolate that knee joint so we can test just that part of the brace. This is a video, actually never mind. First, for all of our fatigue testing stuff, we have been stopping the rig every 15 minutes, and we gather data on the brace angle and the force required to move that brace plus or minus 10 degrees. So right here was just us measuring that angle, then we use a force gauge to push on it, that 10 degrees, and record the number from that force gauge readout. We test these things at about 2.5 hertz, that's 9,000 cycles per hour. On the next slide I have a video of that running. We've also been testing the brace sizes 1 and 6, that is the smallest and largest brace, so we can get the full picture of how those braces interact with the long-term use. Here's that rig running. These are our testing results from these two fatigue rigs. We've had both of them running almost non-stop in Fry 70 recently. You've probably heard it if you've been down there. But these are our results currently. So, just to orient you toward this graph, we have 3 major data points here, and then one kind of more result-oriented thing. So we have the blue dotted line that represents the force to flex negative 10 degrees. The solid blue line is the force to flex positive 10 degrees. That orange line is the neutral angle. And then we have this big black line, which is that first discoloration that we saw. That first discoloration occurred at 19,000 cycles. More on that in a moment, but that is very important for our end conclusions here. The stars at the bottom of the graph represent where we had to stop testing for more than an hour and come back later. This is important because we do not see any major spikes or valleys in the data at any of these points, which means the brace isn't basically bouncing back at those points. There's no viscoelasticity to this thing, so it's not really recovering from its fatigue between our tests. Also worth noting is the forces for both directions, the blue dotted line and the blue solid line, are nearly identical. That means that we've been doing our data collection correctly, we're not missing anything, we're getting the exact same things every time, which is perfect for our results. We do have this large drop in the middle, but we determined that that was just simply user error. We think we had someone new running the test at that time, and that's what caused that little mistake there. But our conclusions from these results that we were able to gather are that, well, first off, prior research that we found has determined that the infants kick approximately 35,000 times per day, or I should say more accurately, move their legs 35,000 times per day. Our machine can do 9,000 kicks per hour. However, those criteria, that 35,000 that I mentioned, quantify all leg movements. That's leg adduction, abduction, hip flexion, and anything involving the knee. So this is kind of a overall large category of motion, and we're trying to hit just one specific thing. And also, our kicks are a relatively large amplitude for an infant, which makes that an even smaller subset of that number. The clinicians at the Cure Hospital in Kenya have observed that discoloration that I mentioned before after about 6 months of use. That does not happen after every single brace is used, but that happens fairly often enough to be a consistent observation. Therefore, we can say that that first discoloration we saw around that 19,000 cycle mark is our 6-month mark of use. And if we treat our data as though, if we can say that we've run the machine for this long, we can say we have this many cycles, we can conclude that the CCB will maintain Clubfoot correction for at least 18 months of constant use, because we had no large force drops over that entire time, and the brace maintained its angle and force output. In conclusion, for the fatigue side of the project, the current Cure practice of discontinuing brace use after discoloration is very safe and appropriate. However, if a child comes back for the checkup appointment, which occurs every 6 months, and the clinician notices the brace is discolored, there is no need to be fearful about the quality of the child's treatment. We know that it was perfectly fine the entire time, because our data says that that CCB was still outputting the same corrective force that entire time it was being worn. And with that, I'll have Bennett discuss our force analysis.
Thank you, Josiah. So the group before us last year made a data acquisition system, and what that did was they put 4 force sensors on both the Steenbeek and the CCB, as listed above, at the correction forces. So it's abduction, eversion, dorsiflexion of the heel, and dorsiflexion of the ball of the foot. And they made it easily removable and interchangeable so that they could run it on different test subjects, as well as interchange between the CCB and the Steenbeek brace. This is a test that they ran in Kenya this past summer, and they did 33 total tests, 20 of those being in CCB and 13 of those being with Steenbeek. And they would do 15 minutes intervals to get the full set as if it was during the day, and then every movement was denoted so they could compare that to the graphs and the forces they saw. So, oh, I got it. So this is a breakdown of which tests could actually give us results that we could do data analysis on. So for example, CCB, although we had 20, 16 of those gave reliable data that we could use for our data analysis. And out of those 16, it was broken down with 1 dorsiflexion of the heel, 4 abduction, and so on and so forth. This is what the raw data of the 4 sensors we received. And as you can see, it's bits over times, and all 4 of the locations are present. Because of this, we needed to change it to newtons and then run through filtrations by a low-pass filter, so no unnecessary noise was present, as well as a threshold of 0.2 newtons, and then we could run our data analysis. So this is the raw data you saw earlier, and this is the filtered and cropped data. As you can see, the dorsiflexion of the heel was removed, and that was since it just did not pass that threshold, as well as it was shortened because the beginning and the end was removed. And so now we were able to get our metrics. So what were our metrics? So we wanted to look at the magnitude, which we use the mean, which is the average, and we wanted to then look at predictability, which is sample entropy, and that just compares segments of the whole thing together. And if you get a value, a high value means it's not predictable, and a low value says it's very periodic and predictable. And then DFA just shows the complexity of the noise, and that is detrended fluctuation analysis. So both DFA and sample entropy has been used in biomechanics studies as listed above, and what DFA found was like a noise between 0.5 and 1 was ideal, 0.5 being white and 1 being pink. And they did say that leaning more towards 1 was more persistent and controllable. And then for sample entropy, this graph shows what it looks like. So a high sample entropy was random, and a low was periodic. And what they found that not too high or too low was favorable. And so there's other studies who show a chaotic range, and that's more human-like predictability. So what did our results show? We used a t-test to determine if they were significantly different, and we found that the mean and sample entropy were significantly different with a confidence level of 90%, while the DFA was similar. So what does this really mean? So if we look at the DFA, we can say that the pink noise, the close to 1 that we saw in other studies, is what we were receiving, and thus the braces are both acting efficiently. If we look at the magnitude, and if the magnitude of the forces to correct and prevent relapse is the ideal case, then it is clear that Steenbeek is better than the CCB. However, Maine has been seeing tremendous results at their clinics, so that's where we think predictability falls into play. We think that the Steenbeek is too high and falling in the more random noise, when we want the more human-like behavior that corrects the relapses, and that's in the chaotic range. So we can say that the CCB is a worthwhile alternative as it reflects a more human-like predictability, which is favorable in preventing relapse of the bracing phase of the Pensati method.
All right, thanks, Bennett. With that, I would just love to close this presentation by giving a huge thank you to our clients and support system here at the Collab. Thank you to Mr. Cunningham, Scott Reichenbach for giving us this project. Thank you to Dr. Geraldo, Mr. Watkins, and Mr. Wilkins for just supporting us every step of the way. And with that, I would love to ask if you have any questions on our work. Yes. We have wondered about that, but I think for the most part it wouldn't affect anything because the forces are reasonably the same. It's at the same location that the infant will be kicking, so we decided that the testing frequency was still safe to use. Yes. Yeah, so the question is exactly how long is this brace being used and what is the brace, I guess, wear time? In general, an infant wears a brace for about 6 months because they grow out of them. So it's typically 1 brace per 6 months until they have a new one and it size up.
Yeah, so the question was about sample entropy and how it's more like the chaotic range, human-like. And so, yeah, based on studies, especially like human gait, they found that being really predictable in your sway or random in your sway could cause like more injury prone. And but people who were like kind of in the middle range were like is more like fluid and more like kind of just kind of like the natural human body movement. And so with that in mind, we're thinking that because like braces are supposed to like correct and like heal to like the natural human movement, we think that it's falling in this like chaotic range that which is ideal because also when you people feel like would be preferable if their braces like they could have more movement and just be more human like while wearing.
We can take one more question. All right then. Thank you for coming.
Thank you.